Okay, so welcome. I want to thank you for joining us for the last of our NNECTR Fall Seminar Series. And we're joined by a panel of experts on applied AI and clinical practices. And it's such a timely topic, which has the attention of a lot of individuals related to healthcare and healthcare delivery. So we're going to be talking about applied AI and clinical practice, studies, trends, and a vision of the future. Before I get started, I want to ask you to feel free to turn your cameras on. It's really helpful to our presenters to be able to see the faces of the people that they're presenting to, but also then to turn your microphones off for the presentation portion of it, and we'll have you turn them on during the QA session, which will follow this presentation. Feel free to put questions in the chat as they come up to you, sort of a placeholder, but we'll address those in the QA portion of the seminar. And we're going to hear from our panelists about pilot studies here at UVM Health using Ambient AI in the primary care clinical setting. Our panelists are going to discuss the multiple uses of AI in clinical practice and research, including large medical models, and discuss what's on the horizon in terms of AI. I'll take a minute to introduce our panelists. So thank you, the three of you, for being our panelists for this topic. So Alicia Jacobs, she's a clinical informatics medical director at Wellbeing Informatics for UVM Health Network and a practicing family medicine physician and professor at UVM LCOM in the Department of Family Medicine. Julie Lin, medical director of the clinical informatics at UVM Health and associate professor of dermatology here at UVM College of Medicine. And Allison Sullivan, clinical informatics specialist, informatics medical director and applied informatics, UVM Health Network, and associate professor for the College of Medicine Department of Emergency Medicine. We look forward to your discussion and presentations about how AI is currently being applied in our clinical practices and what is the rapidly changing landscape in our near future. So thank you all for joining us.
Great, thank you. That was a great introduction. So I'm Julie Lin. I'm going to kick it off, and we're each going to talk for each about 10 to 12 minutes, and we'll leave the remainder for questions. Okay, so this is us. For those of you that don't already know, we are UVM and UVM Health, and we are in the northwest corner of Vermont, and we are a six-system hospital with Burlington being the medical center. And I thought I'd just kind of pull a little bit here about who our audience is as we go through kind of our talks here. So who is familiar with Emma, with AI right now? Looking for any hands up. I apologize, I kind of lost the view. Okay, good. And who's a dabbler, they would say? Who feels like they're really competent? What about expert level? We feel like people are like, I'm in it, I breathe it, I love it. Okay. All right. So, and okay. So that was kind of our poll of who's using it. And I would just say, like, does anybody have any favorite AI apps they're using right now? Or something that they think they're doing well? Feel free to just put it in the chat. Don't see any yet. Yeah, so there are so many tools out there right now. And I would say my favorite app of the month, called Gemini was there, is actually for my clinical care, is Open AI, or I mean Open Evidence. So if you guys haven't used that, I would definitely say look into it. It is free, and it's a huge data set of clinical literature. But besides, professionally using AI, I like to do fun things. So my favorite current AI tool is using Gemini, using like a time machine, just creating images. This is not mine, but AI can create new impossible creatures. You probably don't need your Photoshop skills anymore. So, there's always this tension between, is this art? Is this copyright infringement? Are you stealing? Because now you can compose music, write books, write rap songs. It's almost whatever the human can imagine, you could probably ask some large language model to do it. So for those that are the naysayers, I would humbly say that the train has probably left the station. It is not going away. AI is not a fad. And we can tell by some informal data that it's already embedded in a lot of our workflows already, whether it's obvious or not. And when you think about AI, what can AI do? There's many different ways to conceptualize it, but this is a table by function. And as you can see, it's pretty broad, but it all works on the same premise of the probability and trying to predict the next step based on a training set that it's trained on. But what's caused all the hype recently, because AI has actually been around a very long time, but has been in just different stages of development, is the concept of the generative AI, which uses the concept of large language models. So for those of you that I don't have a, I'm not an expert of the nuts and bolts of AI, more the application, but the way the large language models work, you want to just think about is they devised a program that basically trained on all available data publicly on the internet. So it read the entire internet to try to learn how we think, respond, and talk. And it's trained to understand and generate human language. And what it does is based on its understanding of reading the entire internet, it's looking at patterns and structures and trying to think probability, what is the next step? So it's trying to predict the next step. So it's able to generate new and original content. And this idea of when you type something in ChatGPT, it's called the prompt. If you put in the same prompt 5 times, you're going to get a different output every time. It's not going to be the same answer. So basically, software that's trying to model us. That's the whole term artificial intelligence, trying to act like us, even though they're not real. So as I mentioned, most of the large language models like ChatGPT, Gemini, that's made AI come to the forefront of the public and all the hype, was training on words, but it can also train on many different data types. So for us, it can, train on medical literature, genomic data. It can also train on non-text, so images, so our medical images, clinical photos, surgical videos, and also audio data and listen to sound. So I'm just going to kind of quick 40,000 foot view very quickly of what people are using AI for right now in terms of patient care, what's kind of actually in production, and Allison's going to go for what's kind of in future production. So in terms of patient workflow, there are now AI agents where patients can go to a website and have a very conversational experience to help them navigate a website. So similar to when you're on an airline and you're on Delta and there's that chat bot in the corner and say, how can I help you? Patients now can go and help navigate websites of, what's the schedule for the lab? How do I get an appointment? It can summarize for them visits and billing in layman's terms. It can receive responses from that it's AI drafted at the patient portal. It can create reminders for patients. They've done stuff as remote monitoring where they can analyze the video to predict fall risk. And then there's actual virtual care, telephone and visit, where it feels like a human experience, where some people don't even realize that they're talking to somebody, or there's a video of a person talking to you to do pre and post examples, procedure visits. So prepping for a colonoscopy or post colonoscopy, a phone call to see how you're doing, any problems. On the provider facing, a lot of it is focused on efficiency of practice to decrease the cognitive load and some assistance in diagnostics. So there's also the AI agent that you can have for the provider. So if you're in a patient's chart, you can type in conversational, what happened to the patients when I last saw them. They can say, oh, the patient's been admitted, then discharged, they had a bout of CHF. What most people know about it now is the generative AI notes. So listening to the patient provider interaction and generating a progress note. But it can also summarize lots of text. So discharge, hospital course, transition of care. It can help with medication orders. Right now they're working on voice recognition. So as you're talking, pending orders for you in the EHR, helping to read the formularies for payers to say, hey, if you order this med, this potentially could be accepted or rejected. Analyzing images, detecting nodules on radiology imagings, or counting mitoses on histopathology. There's software called Gleamer that can help with fracture detection. What I'm most excited about is also filing discrete data for you. So we have that world of paper faxes being scanned and nothing really living discretely in the EHR, and then a lot of coding and billing suggestions. On the system side, they can look at system usage data to suggest optimizations in terms of the OR usage, ED and inpatient beds, and staff scheduling, looking at population health with outreach campaigns for flu vaccines, colonoscopies due, and then larger systems of finding people that are eligible for clinical trial enrollment, predicting sepsis in patient populations. And then back office, which is a huge administrative burden on a lot of small offices and large health systems. So helping with in-basket messages and results. So drafting responses for providers and nurses to respond to as a rough draft to send to patients, helping with translation, reading the in-basket messages and potentially trying to suggest urgency, like you should look at these 5 messages first. Same with billing and coding and at this part of the workflow to help with coding edits, in addition to helping with prior auth and pre-cert appeals and letters. And as I mentioned before, being able to convert outside data, so a paper fax or scanned media using optical character recognition and converting it to PDFs and filing it into discrete areas in the EHR. And then in terms of research, I think what I'm most excited about is discovery. So there's a lot of potential for drug discovery development, looking at new proteins and pharmacogenetics, potential new insights and associations, looking at rare diseases. So what I think the biggest potential is to accelerate scientific discovery, because what AI is really good at is managing large volumes and data sets and being able to look at it faster. So a big example is, 23andMe, I think, filed for restructuring. And if some AI company were to buy that information, they could mine the genetic data of thousands of people to look for any associations or insights based on that. So we just kind of don't know what's in the pipeline. So this speaks to the idea of the large language models that have basically trained on the internet and all the available text. And I think there's a new term emerging, something called the large medical model. So the whole idea is they've trained on everything in the public domain. And what I see potential is training on medical data to be able to understand how care is delivered. So what that needs is most of that data is not in the public domain. And there are people trying to do that. So it's been happening in pockets and piecemeal right now. People have tried to make their own medical, large medical models training based on organ set. And if you can see here, there's just a split of up until 2022, almost nothing was happening. And then those graphs are like the number of publications that are happening of large medical models in healthcare by organ system and kind of the topics that they've been trying to publish on. So you see medical writing, education training, diagnostic training, so a whole variety. And then nationally, this is just kind of data about large language models and in terms of medical contributions across the world, what's going on and the type of publications that are happening. So to leave it with the concept of the large medical model, if you can imagine a world where there was a single large database set that trained on our medical records. So right now, AI doesn't know how we take care of patients because that's not in the public domain. Our notes, the events that happen there. And this is just an example of Epic, which is one of the larger vendors in the country, where they are actually trying to train AI to learn how we deliver care and understand it so it can predict the next medical event in a patient. So you can kind of see how powerful that is because of the large volume of data that this particular vendor has. So I think it's going to be hard to predict where AI is going to be the most helpful. I think right now it's definitely helped with the administrative burden, and that's how I'm going to leave my next talk, my next co-speaker to talk about what we've done with generative AI at UVM. So without much ado, I'm going to leave it to Alicia.
Great. Thank you very much. We're going to really segue now and do a deep dive into the studies we've done at UVM Health. You are a primary care research network, and we wanted to show you how we've been looking at the rollout of this product. And I hope that it will help us have some conversations about where to go next, even as a group or regionally. And not even just in Ambient AI, that all of this is ripe for studying, and we're excited about the impact it has on the healthcare workforce. So to make the case, if you don't mind going to the next slide, Julie, I know you guys know, but many healthcare workers, providers, feel that the EHR is a burden. It's the documentation burden. This is everyone, not just primary care. And then next slide. And you can see that is risky because it at least contributes to burnout. And most of the burnout physicians, at least almost 2/3 of them, feel that it is related to, or the EHR contributes to it. And you can see at the bottom there, but there's an actual fiscal note or risk of burnout, because as people leave the workforce or make moves to try to find something more manageable, it really does bring a lot of cost to the system. All right. So at UVM Health, nearly 2 years ago, actually, a year and 10 months ago, we embarked on a double crossover study of using Ambient AI listening products to generate notes in our clinical practice. We decided to study it and actually study vendors. This is in some ways old news now because, well, it's been almost 2 years and they're almost, I would say, like current practice in a lot of different places. So the short story is we developed a study design of 50 primary care providers who were volunteer participants in a double crossover study. It was designed as an 8-week study with a pre, mid, and post survey, where half of the group used one vendor, the other half using the other vendor, then they crossed over, and we were able to evaluate not just the impact of Ambient AI, but the two vendors. And this is just a roll up of what we did, our timeline over the entire year. We started with this study. I'm going to show you the results in just a minute, but we ended up embarking on a year-long sort of thoughtful, sustained rollout to our entire healthcare workforce, to the point where in March 2025, we got an enterprise license with our current vendor, and we really are fully integrated and have this available to all clinicians now. And next slide. And I would just say, these are the data points that are generally fairly interesting in terms of following how this impacts the workforce. And I'm going to give you some data on the abridged utilization surveys. We did not do patient surveys. I'll just tell you right now, patients did give us, we have informal feedback that it has impacted their experience as patients, where clinicians are much more present and focused, and they actually feel like they're bothering clinicians less. Literally, some people said things like that. And then, of course, EHR usage data. So on to the next slide. And I have a lot of data slides. I'm going to go fast because I want to stay on time, and we can always revisit them if you want. This is from our survey data. We actually did surveys at we did a survey after the double crossover study. So that's the second survey, the 8 weeks. We then did a follow-up survey at 4 months and a year. In 2 months, we'll be coming up on 2 years and anticipate resurveying this cohort of participants. But if you look at the top line about the percent burnt out, you can see the pre was 69%. This was a volunteer group. I think that is higher than average at our system. You can see the phenomenal drop at 8 weeks, even more phenomenal at 4 months, and maybe a little rebound at 1 year. But we all like to say there was an election in between that 4 months and 1 year. But still, pretty impactful, sustained response at 1 year. And then if you look at the next row down, you can see the level of professional fulfillment came up and stayed up in a sustained way. So again, these are data about what the providers are reporting about how they're using the EHR. They are still reporting using I'm sorry, let me regroup. The impact was great, except in the low utilizer group. So if you can look to if you can see, I'm going to have 3 slides. On the left column, you can see all of primary care users. Then the next column is non-Ambient AI users. And then we split it out by how often these providers are using the AI in their clinical practice. And you can see the percentages, low, medium, and high utilizers. So there's really like a high impact on decreasing charting at home in the mid and high utilizers. We know we need to look at this low utilizer group and understand, because let's go to the next slide. You'll see a pattern here. We use a survey to evaluate our EHR through the Arch Collaborative or CLASS. They have a net EHR experience score. And again, this score went up, meaning people were more satisfied with the EHR when they had a bridge and were using it in the mid to high range, whereas the low utilizers stayed less satisfied with their EHR. And then one more slide, breaking it out by utilization again, and you can see the pattern again. And there's a correlation between higher utilization and lower burnout. So let's go to the next slide. I wanted to put a slide in here because we don't entirely know why people don't engage when they don't engage. We think it's these type of issues, and it's not all one. And so that is one of the places where we are hoping to explore more and figure out how to engage the unengaged. All right, let's go on to the next. Now, these are not statistically analyzed slides. These are just showing some trends in EHR usage. So this is Epic signal data, and it's all normalized to when the primary care providers started using the Ambient AI, and you can see a trend, and it's about a half appointment a day more since starting to use Ambient AI. And the top graph shows that. The bottom graph is distance from peers, so it helps control for other factors in the system, but you can really see how that has increased over time. The next slide, again, EHR usage data shows level of service coding, and I believe it shows a trend of higher numbers of level 4 visits. And then the next slide shows a downward trend in time in system. And that's what we're after, right? So let's go. I'm going to segue from our primary care study to just say that we've also done 3 other studies. One is a note quality study where we used a modified PDQI-9 to evaluate both AI and provider-generated, provider-written notes. And the short story is, at least with a bridge, the vendor we went with, the notes were non-inferior. They were rated the same. And then next slide, we also did a survey of patients' perception of the note quality. And I would tell you that they felt like the note was non-inferior, if not better, and may have had fewer errors in them. And then I'd like to segue to our GME study, because this felt really important to us, this data. And so here we modeled a study in our primary care resident population. It was not quite the same as our primary care study because we were not doing a double crossover, but a rolling start where we surveyed at 0, 1, and 3 months. We got pretty high participation from the primary care residents that were eligible to participate. And the next slide will show the roll-up of what happened. Decrease in cognitive load, just like the attendings had, decreased time and notes. I'm going to show you some of this data. And so I'm going to go on, but I wanted to give you this roll-up slide. So let's run through the next few slides. So this is resident hours spent writing notes during a session, down, and trending down over time too as they got better at the technology. But then here's the caveat, the next slide. which is that their total hours did not statistically significantly decrease. And you can see that wide range, and we're not sure what that means. So this is a curious data point for us. And I don't know if it's some people are perfectionists or spending a lot of time editing the ambient AI nodes or what's going on. So we will be looking into this further. Let's go to the next slide. The mental demand for writing notes, statistically significantly down. Next slide. The time to complete patient care messages. So in other words, to do other work. So work on their in-basket, take care of phone calls and portal messages was increased. Let's go next slide. Residents felt like it supported their ability to have a therapeutic relationship in visits. And next slide. Their burnout. Now this is interesting. It was down significantly at 1 month, but it was not sustained. And again, we're going to resurvey them around, it'll be around 9 months. And we're interested in what trends we'll see there. And let's do one last slide that I just love, which is that they all felt like they had more time to learn medical topics, which, by the way, is what residency is supposed to be about, not just learning how to practice. So we were thrilled to see this. And now I'm going to hand it off to Allison for the future.
All right. Thank you, Alicia. Actually, before we do that, I see we have a question in the chat, and Paul had asked, were the sample sizes the same? I'm not sure which
sample sizes, Paul?
The confidence interval looked bigger, and so I assumed that the explanation for why we didn't see any, the error bar rather, one easy explanation for the would be a smaller sample size for why the bar was so big.
Oh, I think we only analyzed we only analyzed for the participants that did all 3 surveys. So I don't think that would be true in this case. Does that make sense?
Okay.
Yeah.
Alicia, did you do the same surveys of the attendings in addition to the residents, and was the data similar?
It was similar. I did show you that the burnout was sustained for attending. So that was a different finding in the residents. And we really do want to follow up on that. Yes, there was a lot more data in the attendings. We had very similar surveys with those additional topics about learning and capacity to learn. Yeah.
Thanks.
All right. Thank you. So I got to talk about a vision for the future and how will AI actually change healthcare. This is kind of fun for me, although a little bit hard, because I think predicting the future is a difficult task. But the fun thing about presenting this section is that I can choose a version of the future that I want to, and I'm choosing a hopeful, optimistic version of the future. But I do think, AI transformation of healthcare is going to depend a lot on the choices that we make, what we choose to prioritize, what we choose to incentivize. And hopefully we'll see AI actually remove some of the differences that we see currently in, barriers to care. So I'm choosing a hopeful, optimistic version. But let's go on to the next slide. Thank you. So I don't know how many of you heard about Apple Watch's new hypertension detection feature, but I think we're going to see more and more things like this. There's a lot of patient wearable, a lot of data out there that has the potential actually to really help screen for disease. I think that will become a lot more widespread, and we're going to see new applications. For those of you who aren't familiar with this, this came out with Apple's I think their last version of the Apple Watch. And they chose like a really kind of interesting approach and algorithm where it flipped our typical approach for screening for disease, which really goes for like sensitivity over specificity. I think they were very intentional actually about really trying to be more on the specific side so that they're not inundating primary care offices, thankfully, with a bunch of people who actually don't have hypertension. So this will still improve detection and screening rates, but hopefully won't overwhelm our healthcare workforce. The other thing I think a lot of the AI development has been on the provider team so far, but I think we'll see that also flip to patient facing. So some of the health data questionnaires that we ask patients to fill out, a lot of those things, paper forms even, are very manual processes, but we'll start to see those, the capability of using natural language processing and ambient moving that language into discrete data like it's doing for us on the care team side. Let's go on to the next slide. The other thing that's out there already too, that is probably we're going to be seeing more and more of is really development of AI tools that are intentionally patient-facing and can give rapid, high-quality medical advice. So a patient can access this at any time of day, any time of night, whenever they need it. And it gives really reliable information to them in an available and really understandable way for patients, and that can be contextualized to their individual medical history. If done right, I think this really has the potential to improve access to care by offloading care teams from some of this information and messaging that we don't really need a healthcare professional to give that advice all the time. So I think this could help patients stay healthy, help avoid unnecessary visits, and give them the answers that they need in a really rapid time frame. We can go to the next slide. Where I think we're going to see some of this is already happening, as Julie talked about early on, that there's a little bit of uptake of patient scheduling via text, and via AI phone trees. But I think we're going to see this more and more so that patients can interact with an AI chatbot who's not overwhelmed and always able to be flexible with their changing needs and changing schedule to really help them individualize when they can make those appointments. We'll also see, I think, more AI-generated communication to patients from healthcare offices, reminders about appointments, needed screenings, instructions, which has the potential to improve miss rates for screening appointments, or not getting those follow-up recommendations for another imaging study scheduled, for example. So we can go to the next slide. Additionally, I think some of these tools are in development now, and actually out now, where there's other platforms that sit atop an EHR. They're not in our big EHRs yet, but which will help give differential diagnosis generation based on the patient chart. And soon we'll integrate, I think, the conversations that we've been having with our ambient recording devices will really help make sure that we're not missing certain things in our differential diagnosis. So help augment physicians in that way and care teams in that way. We'll also see more in workflow decision support that's less interruptive and intrusive, but also giving up-to-date medical evidence and advice about what we should do with a particular patient. This is already happening in some places. There's I don't know how many of you saw it, but a trial in Kenya, a place called Penda Health, primary care offices, and OpenAI collaborated to conduct a study and showed improved diagnosis and management of the patients in that study. And the providers actually really loved it as well. So this was seen as a a win-win for patients and providers.
Mhm.
We can go on to the next slide. I think we'll also, there's so much data and so much medical literature out there. I think it's hard to know, I think this group probably knows that there's variable quality of that. So trying to stay up to date and abreast of new information and also high quality information, I think AI will start to assist us in that as well, both with peer review and also making sure to help synthesize perhaps differing results that come out. I think we'll also see tools that can help assess and pull all together those different results and feed that information to our care team members, both on shift while you're working in your workflow, but then also, in perhaps another form that you want to consume it in a podcast or a video, maybe an AI generated video. We can go on to the next slide. This is another thing that's happening currently as well. We have assisted imaging reads in radiology, as Julie mentioned, with fracture detection. This is going to happen even more. Currently in development, radiology assistance that actually reads a whole study, like that fracture detection one. It doesn't catch dislocations. It doesn't see if there's a bone met, for example, but that is being developed, and I think we'll see that more broadly adopted. Also, within that, helping prioritize which things need to be looked at next by the radiologist. So the AI could detect, of all of the CAT scans that were done, this one looks like there's a brain hemorrhage. We're going to bump that right to the top of the radiologist list. In addition, pathology detection, not just in radiology, but in other fields where, for example, colonoscopies, there's been some research showing improved rate of polyp detection using AI to help find those polyps. We'll see this more and more in any fields that use imaging, perhaps coming to dermatology too, Julie. And then we can move on to the next slide. You knew I was ready. As we've seen a lot of the ambient documentation so far on the provider workflows was starting to move into nursing. And I think we're going to really see reduced need for manual documentation tasks that are discrete data that ambient listening could capture and document for nursing staff. This will really greatly reduce that need, and I think offload our nurses, which will be fantastic. Also reduce need for manual calculation. A lot of times when we are titrating medications such as insulin or heparin, we're integrating information from a lab value. Nurses then have to manually calculate what the adjustment in the dose is. I think AI will start to help with this so that we're taking that off of the nursing workload. It'll also enable monitoring of vital signs, early detection for deterioration, and help predict when there's a need for higher staffing ratios. We can go to the next slide. So we're already seeing, again, on some of this, but I think we'll see this more and more widespread on the billing and revenue side. On the provider end, we're going to see assistance with coding, denial appeals, assistance with prior authorization, but we're going to see a lot of AI on the insurer side too. So in the end, I'm not sure what's going to happen with the financials, but there's definitely development for fraud detection, risk assessment of patients, and automation of reviews of medical data. Let's go on to the next slide. So for research and treatments, I think there's some really interesting stuff happening here. I think AI definitely has the potential to assist with drug discovery. I don't know if any of you on here has heard of the company called EveryCure, but it's a really interesting organization. The founder of the organization is actually a physician who had Castleman disease and discovered his own cure through with a medication that's sirolimus used for other applications. So he has started using AI with EveryCure to help look at existing pharmaceuticals and whether they can be used for other diseases. There's no money in that, like nobody's funding that from like on the pharmaceutical side of things. So this really, I think, could be a really interesting way to help discover already existing treatments that we have for new applications. It could also help with making sure that we have optimized dosages. A lot of times when we have studied pharmaceuticals in the past, it's impossible to actually figure out like what is the ideal time frame and the ideal dosage. And I think AI could help optimize that. I do think another interesting application on the research side is the pattern analysis. This is kind of similar to predictive analytics, kind of similar to some of the stuff that Julie brought up at the beginning with the large medical model. In emergency medicine, we love risk stratification tools to help us figure out like, how much do I need to work this patient up? With the vast amount of data now available in these large medical models, I think we'll be able to see a lot of predictive analytical tools to help us with that risk stratification. We can go to the next slide. One of my favorite potential uses for AI here too is really that improvement in pharmacogenomics. Again, something that Julie brought up originally, but I think this really, AI really is going to make this a lot more possible to help, based on the unique person, their characteristics, their genomics to better predict which treatments will work for which individuals so that it's not just a statistics game trying to find the 20% of people that actually get better with the med. And the concept of virtual twin is really taking the patient genetic information, creating a computer kind of copy of them, and then being able to try the treatment virtually before actually giving it to a patient. And next slide. So, I think in translational science here, like I think AI, kind of pulling in some of these concepts I think AI is going to assist us with the implementation science and the rapid translation from research to clinical care and help narrow the gap between when we know something from medical evidence to when patients are actually receiving it at the bedside. And I think that's really my last slide. So I will stop there and take any more questions.
So I welcome people to take their microphones off mute and ask questions or put their question in their chat if they'd prefer. I was thinking about some of the things that, as you were speaking, and this is with my research brain on the opportunities here and sort of retrospectively thinking about some of the activities that have happened here. One of the slides you talked about AI tools that help guide you in decision making. And I think back to not that long ago, Barry Finette's tool that he was creating for the pediatric population that was along the similar lines where triaging symptoms and where to go for healthcare type of thing. So I feel like some of our researchers here have been thinking along these lines for a while. So, Gary.
It's, one application is being able to go ahead and to do analysis of pathology specimens, where now you can look at up to 100 proteins and nucleic acids in a specimen and understand the tumor, the microenvironment, and that's very, very valuable in terms of both diagnosis and prognosis. And I think the applications there are infinite in terms of research and also extrapolation to clinical practice. But I have a practical question. Um, the ability of utilizing AI to be able to provide responses to patient inquiries can be incredibly informative, but um, are those responses checked before they are conveyed to the patient?
Yeah, yes. I was just going to say there's this concept of human in the loop, human on the loop, human out of the loop. Right now, it's human in the loop. So it generates a response for you to preview, similar to the generative AI. And you can choose to reject it, accept it, edit it before you send it. So I would call it a rough draft. It's not automated and nobody sees it at this point, at least at the systems that we've seen.
It's incredibly valuable at that level. Thank
Yeah.
you.
No, and it's a good point. I would say that there's definitely research into could we develop some tools that would be able to do it without a human checking. I think we're very risk averse for sure. We don't want anybody to get a hallucination from an AI model. That's just not okay in medicine. So I think we have to be pretty cautious before we'd want to take the human out of the loop, I think.
Paul.
Thanks, everybody. Enjoyed that. My brain is also leaking because I was just for 6 days at an AI conference, essentially at AMIA, so up to my eyeballs. But one of the things, actually, to follow up on Dr. Stein's comment, is that was a demonstration model of a so first, almost everything has retrieval augmented generation now applied, so it's domain specific models that really reduce hallucinations dramatically and then increase the depth, specificity, and relevance of responses. But what on that particular item, there was a demonstration project shared that actually has an ongoing conversation with patients so that they can really get a very informed, rich message to the doctor, craft their message. It's assisting the patient messages so that the doctor receives a very detailed, so there's not a lot of back and forth, which is really where the time is back and forth, back and forth, and back and forth before making it, or just come on in because I don't have time to talk on the text messages. But anyway, that was really, it got big applause, so I'm sure that will be on its way into vendor products. But my question was just this whole, I would say 90% of the presentations and workshops were on agentic AI, where it's multimodal and not just LLMs prompt to text, but um, having a committee of LLMs essentially, which not only have text outputs, but would have transactional outputs so that the model can do things. It can take the input of the image and then render an order set or, file things to a public health data, the cancer registry, semi-automatically, that kind of thing. In fact, the public health implications were absolutely enormous because it so dramatically reduces the cost of data extraction, especially when compared to a FHIR software platform, which has standard concept mappings. So my question really was, are we in Northern New England, anyone know of any of these agentic projects that to leading to either public health or other use cases? Because I saw a million examples, but I was like, we're underrepresented. Anybody know of anything happening here for that type of research?
I'm not aware of anything, Paul, but I could do a little searching.
Yeah. Yeah, one of the nice things is most of it's open source, so it's not like we couldn't do these things. Yeah.
We do have a couple of comments in the chat. Howell is talking about keeping in mind the cost, the environmental cost of AI, and how that can affect the power and water resources for small communities, and then the ethics of that. And then Marie is talking about primary care physician. Would love to have you speak regarding upcoming AI agents that will help the process of all patient entered data and device data coming in.
I would say to Havilah, I totally agree. I think we have to be really cautious and thoughtful about what we want to develop. To some degree, I guess it's not really, there's tech companies out there that are gonna develop what they're gonna develop. But I do think we should have a strong voice in that and try to influence it into things that we actually think will be really helpful to make some of the cost worth it at least. Um, Marie, I'm curious, was there something specifically you had in mind, like a tool that you've heard of or?
Just when I was at, I think my Wi-Fi is terrible. Epic UGM, they were showing the patient enter data coming in, the device data, and it actually like bringing it in as a graph with all the information like integrated and analyzed. And I literally had like took a breath and felt so much better because I just imagine the future when we'd be getting so much data and like how would we manage that? So I think it's really important for our clinicians to know that there is a thought of like, if all this information is coming in, how will it be presented to us to actually be manageable and actionable? Because otherwise, it just feels so incredibly overwhelming with patients wanting to send their device data. So I just wanted to say that.
Yeah, I think that's a really good point too. And something that we have to think about is like as there's more and more data, like what we're asking by taking away some of the low cognitive burden tasks, then it makes it so that everything you do is very high cognitive burden, which is just a lot to ask our humans to do. So I do think we have to be mindful of that, and definitely data presentation, the way it comes in so that it's synthesized and you're able to interpret it is really important. But I think we also have to be mindful of as we're offloading our workforce from some of those, that in a way, those aren't chores that we want to be able to do, but we also need some rest, not to be maxing out at cognitive capacity all the time.
Allison, can I ask a question and perhaps throw a comment?
Sure.
So one of the interesting pair that I think that we go into was a premise that this is going to relieve us from having the cognitive pressure and burnout. I am afraid actually it's going to be quite reverse. So we're going to have to learn a lot of new technology, which are not very familiar, but may be very foreign to us. And then as we implement efficiencies, and this is kind of lesson learned, but we quickly forget there's this Jevons paradox that whatever efficiency we create, that gets quickly canceled by expectations that we increased output. And that doesn't come necessarily from the organization itself. It comes because the CMS sees, and they just assign a lower value per RVU. And what it leads it to, just what you were talking about, that you end up working at higher capacity, higher mental capacity throughout the day, and you leave the work even more burned out than before. And yeah, in terms of the part, I also kind of looked into it because this comes up in radiology a lot since 80% of right now what's approved for by FDA is for image and pixel data. And I'm not saying this with any proud. In fact, I'm saying with a trepidation that maybe my job's going to be the first one to automate away. In terms of what's the use of energy right now, it's very small. It's less than 1% for AI from all data centers. It's about 15%. All data centers, it's about 5% of energy use in the US, but it's on an exponential growth. So it is going to increase. And for, just to put in context, small car drive, about 15% of consumption of energy. So just us driving 10% less would cover that AI, but that's for now. But what it's going to be 10 years from now, who knows? And the biggest concern there is how do we actually deliver that energy into such a small demand for energy in the data centers. So that's why there's so much up there in terms of how we supply the energy today. How do we make it consistent, and how does it, stay in production without blackouts? The point about the burnout, I'm concerned about it, and I think we see it already on our end.
It's a really good point, Jay.
Gary.
Yes, just a brief comment. We were involved several years ago in image analysis of breast cancer specimens, and what I was amazed to find out is that the tools were primarily developed by astronomers who were mapping the solar system, and that's where a lot of the pattern formation came from, and it's been incredibly informative. And one of the initial contributors was the Jet Propulsion Laboratory.
Paul, your comment about the standard clinical workflows, and healthcare has such a human aspect to it, and as a nurse, like I just can't imagine, step up to the kiosk and your AI nurse will take care of things. I think that there's going to be lacking components to that and the satisfaction with that, but maybe that's hopeful more than practical. I don't know.
Yeah, I mean, I guess I do think that AI will augment us more than I don't think it's going to replace anyone in the healthcare workforce.
I do think that is the belief of some people, though, and some people with a lot of money who are trying to do that. I was struck at that vision is already prevalent.
No doubt.
I think there are great opportunities in some of the things that we do. So if we can figure out how to partner with AI to improve all things, that's great. I'm currently, from an administrative perspective, dealing with the burden of AI and AI generated resumes and CVs for applications, and it's actually creating what used to be already a challenging process of finding the right fit in applicants. It's generating a lot of noise that you've got to go through, and so it's increasing the work burden there.
Yeah, in terms of our jobs being replaced, maybe I'm more optimistic. I don't think that people dealing with direct patient care, but I see a lot of the supporting jobs potentially being less, like use example transcriptionists. Like that role has almost been sunset. There are very few transcriptions going on with the Dragon, and now we have the Ambient A.I. And I see it happening on the administrative side, like the back and like the coding and the billing and stuff, that will need less of them, and it will just be some master coders that are overseeing an AI system that's going through that. I would feel like that's potentially one of the first kind of roles that might not be gone, but a diminished workforce. But I think we'll see.
Yeah, I like to believe in the sacred parts of medicine, which is seeing the patient. And that is how we can help promote internal healing, which is 90% of what happens with people, right? And so I love the idea of trying to do some inquiry around how can you measure that impact and show the human component that we need to continue to bring to medicine. What a great conversation, everyone. I really appreciate this.
Well, thank you to all of our panelists, presenters, for your input on this and the generating of thoughts around AI in our future. And thanks everyone for attending, and wish